Good morning. I'm Max Kruin. I'm a pediatrician from Mowbray Maternity Hospital in Cape Town, and I'm presenting the final results of our field evaluation of point-of-care HIV testing of HIV-exposed infants. We compared a prototype of the LearQ point-of-care HIV PCR testing system to the standard of care Roche CAP CTM testing done in the regional reference laboratory. First up, I need to disclose that although Lear donated the equipment used in the study and supported my conference attendance, they played no part in the study design, conduct, or analysis. In the first phase of the study, we compared point-of-care and standard of care HIV PCR testing in the laboratory. The findings showed good sensitivity and specificity and were presented at CROI 2015. The second phase was an evaluation in the field, and the third phase was semi-structured interviews to determine user acceptability. The setting is our study was conducted between December 2013 and August 2014 at two public sector health facilities in Cape Town. Known HIV-exposed infants being tested by standard of care were simultaneously tested at point of care with the LearQ Detect prototype. At Mowbray, only existing medical staff were used to conduct the study, and at Gugulethu there was a research team that conducted the tests. Study approval was obtained from University of Cape Town Research Ethics Committee, and informed consent and case report forms were filled in for each participant. This is the device. It has a very small desktop footprint. It weighs only 7.8 kgs and is powered by mains or battery. Process, we collected whole blood into EDTA microtainers by heel pricked or phlebotomy. Then a 25 microliter sample was introduced to the cartridge using a plain glass capillary tube. Cartridge, then close the cartridge, insert it into the machine. The patient and user details entered via the touchscreen, and the results are available in approximately 55 minutes. Initial users had a brief training only, and we used the train-the-trainer approach for subsequent staff. We get quite a high turnover of staff every 6 months or so at Mowbray. Overall, we performed 471 tests on 436 patients. More patients were at Mowbray. And testing at Mowbray was mostly on high-risk infants soon after birth by the local standard of care. Testing at Gugulethu was mostly at the traditional 6 weeks testing point. The 24 Mowbray users were all doctors of varying levels of experience, and at Gugulethu, a doctor, a nurse, and a health assistant performed the testing. The peak daily use was 7 at both sites. And certainly at Mowbray, Mondays tended to be when specimens from the weekend were accumulated and had to be processed on a Monday. Mowbray, of the high-risk infants tested, 4.5% were positive, and at Gugulethu, 2.4% were positive. And just over 10% of the tests recorded an error code. At Mowbray, point-of-care testing detected 92% of the positives, and at Gugulethu MOU, 100% of the positives. Interestingly, the one apparent false positive at Mowbray became indeterminate on repeat standard of care testing on day 3. We had a policy of any baby that tested positive by point of care, we would keep them in the hospital until we had the standard of care result. And also the apparent false negative was a preterm baby after 10 days of combination prophylaxis who had tested standard of care positive at another facility before transfer to us. And this point of care test was done at confirmation of infection when the viral load was 1146 copies per mole. There were a significant number of error code results, but with repeat testing, more than 90% of infants had a point-of-care result. In the laboratory-based first phase, only 6% of point-of-care tests error-coded. So in the field, there was a slightly higher error code rate. Then we did the interviews. These were conducted by one of the researchers of the users. The users thought the device was practical, easy to use, but they were frustrated by the error codes and the occasional stuck cartridge. They also appreciated the immediacy of the result and the potential simplification of early infant follow-up and linkage to care. Their comments tell a whole story on their own. In fact, when the study ended and the device was taken away, they were all quite sad and wanted it back, wanted to know when we would get a device to keep permanently. So there were some limitations of the study. The first was that we were unable to assess patient acceptability as the device and the cartridges were for investigational use only, and we couldn't provide the mothers with the point-of-care result. We didn't have a clear protocol for repeats on the error codes, and the number of error codes were unanticipated, so it depended on how much sample we had and what the user, how often the user felt they would like to repeat it. We couldn't compare with dried blood spot testing because that's not what we do in the Western Cape. We do whole blood. We didn't have enough nurses performing the tests. It would have been interesting to see how they handled the testing. And we were unable to assess the cost of the point-of-care testing. The point-of-care system was found to be adequately sensitive and specific in the field, and by providers to be quick, user-friendly, and acceptable. It would have been good to have a clear approach to resolving error codes in practice, but we should bear in mind that perhaps some of the troubles we had were related to this being a prototype device. And then finally, really good uptake of PMTCT has seen a dramatic reduction in vertical transmission, but means a higher proportion of the transmissions now occur in utero. So it may be that point-of-care testing is particularly suited to testing at birthing facilities where HIV-exposed infants are concentrated, and the consequences of delayed diagnosis, delayed linkage to definitive management are a rapid disease progression or death. The costs and systems issues of field implementation remain to be determined, and it's my hope that we can do a follow-on study to look at these issues. Finally, I'd just like to acknowledge the staff at the National Health Laboratory Service, Mowbray Maternity Hospital and Gugulethu Midwife Obstetric Unit, and the mothers and children who made this study possible. Thank you.